Dear colleagues, welcome in this second day of the conference on the Dialogue for Change on Disability, Social Protection, Inclusion. Yesterday, we heard about different elements, the key demands of organization of persons with disability globally. We talked about the costs of disability and looked at how cash transfer can be designed for inclusion, as well as the different approach to cover healthcare costs and assistive technology. In this session, we will look more in depth at the specific issues faced by children with disabilities and their families. We have available interpretation in different language, as well as captioning and in sign language. If you have some questions during the session, you can post it in the Q&A element, and you can also write comments, as well as address any technical issues you may have in the chat box. We have a wonderful panel today to talk about social protection and children with disabilities, and I have the pleasure to be moderating this session. I am Alexandre Cote. I am the Social Protection and Disability Specialist for UNICEF Headquarters. And we will hear today from experts from a diversity of context. Our first speaker will be Fadia Moustafa, who is representing the International Disability Alliance and Organization of Persons with Disabilities. We will hear also from His Excellency William Kingi, who is Deputy Governor of the Mombasa County, as well as from Flavia Mpanga, who is Health Specialist for UNICEF Uganda. We will also hear from Nora Sharbani, who is Education Specialist and Regional Advisor on Disability for UNICEF in Europe and Central Asia. And finally, we will hear from Ala Darwish, who is Social Protection Officer in Syria. We know that children with disabilities are much more likely to be victims of violence, to be living in poverty, to be out of school, and many other forms of discrimination and inequalities. Social protection plays a fundamental role in addressing part of the issues they are facing. We heard yesterday from our colleague in Georgia, as well as in the Philippines, about the significant disability-related costs that children with disabilities and their families are facing. Without any further ado, I would like to give the floor to Fadia Moustafa to share with us the key issues and elements that the Organization of Persons with Disability would like to share with us. Fadia, the floor is yours.
فادية مصطفى، طفلة ذات إعاقة من لبنان. من المرجح أن يواجه أطفال الإعاقة الفقر المزمن والاستبعاد الاجتماعي طوال حياتهم بسبب انخفاض معدلات الالتحاق بالمدارس وضعف الحصول على الخدمات الصحية والمشاركة المحدودة في المجتمع. على الرغم من إمكانية اكتشاف الإعاقة في أي مرحلة من مراحل نمو الطفل، إلا أن اكتشاف التدخل الفكري يمكن أن يقلل بشكل كبير من الحاجة إلى تدبيرات أكثر تكلفة في مرحلة لاحقة. مع ذلك، نظراً لارتفاع التكاليف المتعلقة بهذه الخدمات، فقد لا تكون متاحة لأسر هؤلاء الأطفال، مما يزيد من فرص تفاقم إعاقتهم وتعرضهم للاستبعاد الاجتماعي. تحمل الأطفال ذو الإعاقة أيضاً تكاليف إضافية لتلبية متطلباتهم المتعلقة بالإعاقة، بما في ذلك الأجهزة الخاصة الأجهزة المساعدة وتكلفة النقل المسير للوصول والوجبات الخاصة والرعاية الصحية وإعادة التأهيل، من بين أمور أخرى. بسبب هذه التكاليف الإضافية تقل احتمالية التحاق الأطفال ذوي الإعاقة بالمدرسة، وإذا التحقوا
My apology,
فإن
Fadia, my sincere apology. It seems that we have a problem. We do not get interpretation. We were supposed to get interpretation in 4 languages, and we are not getting it now. Would it be possible, and I strongly apologize, would it be possible for you to share some of those key elements in English?
Alex, I can help in translation.
Ala? Okay,
Yes.
Ala, if you can support.
Yeah, but
Thank you.
Fadia, please just slowly because I need to follow.
Okay.
Thank you, Fadia.
Thanks for you. فادية مصطفى طفلة ذات إعاقة من لبنان. من المرجح أن يواجه الأطفال ذو الإعاقة بالفقر المزمن والاستبعاد الاجتماعي طوال حياتهم بسبب انخفاض معدلات الالتحاق بالمدارس وضعف الحصول على الخدمات الصحية والمشاركة المحدودة في المجتمع. على الرغم من إمكانية اكتشاف الإعاقة.
Yes, my dear. I'm Fadia Moustafa. I am a child with disability from Lebanon. Just explaining about the situation of children with disabilities. It's more likely that children with disabilities are suffering from deprivation and lack of available services, and the cost of providing these services is more likely to be higher for other. Yes, I'm trying to capture the full picture, Fadia. عم حاول أخذ المضمون فادية، يعني بجوز مو حرفي، تمام؟ بس شوي شوي مشان نقدر نلحق الحكي. يلا تفضلي.
أوكي. على الرغم من إمكانية اكتشاف الإعاقة في أي مرحلة من مراحل نمو الطفل، إلا أن الاكتشاف
خليني أنا أترجم جملة فادية. خليني أنا أترجم جملة. أوكي. Although it is really
sorry Ala, it seems that we have translation now.
Oh, okay. Sorry, I tried to help.
Thank you for jumping in.
That's sure.
Thank you. Fadia, please proceed.
I read from beginning?
No, I think no, from the moment you were now, please.
Okay. على الرغم من إمكانية اكتشاف الإعاقة في أي مرحلة من مراحل نمو الطفل، إلا أن الاكتشاف والتدخل يمكن أن يقللها بشكل كبير من الحاجة إلى تدابيرات أكثر تكلفة في مرحلة لاحقة. ومع ذلك نظرا إلى التكاليف المتعلقة بهذه الخدمات فقد لا تكون متاحة لمعظم أسر هؤلاء الأطفال، مما يزيد فرص تفاقم إعاقتهم وتعرضهم للإبعاد الاجتماعي. أما الأطفال ذو الإعاقة أيضا تكاليف إضافية لتلبية متطلباتهم المتعلقة بالإعاقة، بما في ذلك الأجهزة المساعدة وتكلفة النقل المسير للوصول والوجبات الخاصة والرعاية الصحية وإعادة التأهيل، من بين أمور أخرى. بسبب هذه التكاليف الإضافية تقل احتمالية التحاق الأطفال ذو الإعاقة بالمدارس، وإذا التحقوا فإن نسب استمرارهم تقل مقارنة مع أقرانهم. إن ضمان الوصول إلى خدمات الدعم المناسبة والمتعددة مثل التنمية المبكرة للأطفال والتعليم يمكن أن يعزز تمتع الأطفال ذو الإعاقة بحقوقهم، ويعزز طفولة غنية ومرضية، ويهيئهم للمشاركة الكاملة والهادفة في مرحلة البلوغ. من المرجح أن تكون أسر الأطفال ذوي الإعاقة معرضة للفقر بسبب التكاليف المرتبطة بالإعاقة وفرص الكسب الضائعة نتيجة اضطرار أفراد الأسر إلى رعاية أطفالهم. يمكن أن تكون التكاليف الإضافية للرعاية كبيرة وقد تؤدي إلى تقليل فرص الكسب التي من شأنها أن تحسن مستوى معيشة هذه الأسر. أطفال ذوي الإعاقة من بين الفئات الأكثر ضعفاً وتتحمل أسرهم تكاليف إضافية كبيرة بسبب إعاقتهم، وإدراجهم في برامج الحماية الاجتماعية العمومية الموجهة للأطفال غير كافي، حيث يلزم توفير برامج حماية اجتماعية إضافية للأطفال ذوي الإعاقة وأسرهم. يمكن للأطفال ذوي الإعاقة وأسرهم الاستفادة من برامج الحماية الاجتماعية مصممة جيدا والتي توفر الحماية والدعم التي تشتد الحاجة إليها، بما في ذلك الجمع بين التحويلات النقدية والخدمات والإعفاءات. Thank you.
Thank you very much, Fadia, for those introductory remarks about the perspective from OPDs on this issue. Now, I would like to invite Susan Momaini, who is social policy specialist on the Kenya UNICEF office, who will present the STRIDE program on behalf of His Excellency William Kingi, who is Deputy Governor of the County Government of Mombasa and who had an issue preventing him to attend. Susan, the floor is yours.
Thank you. So for Mombasa County, this is one of the counties in Kenya, and the first county to start or to have a social protection strategy. And in the strategy, they have outlined how they are going to be inclusive for children with disability. So in the design of the Children with Disability program, the program has 3 pillars. One is an inclusive school transport that is very specific towards accommodating children with disabilities. The other pillar is strengthening the skills and capacity for the children officers and also all other officers who are handling children with disabilities. And the other pillar is providing cash transfers to vulnerable households who also have children with disabilities. Next slide, please. So for the program, for us to be able to reach on children with disabilities, of course, there are a number of issues around that needs to be taken into consideration. We know children with disabilities, they represent a vulnerable group. We know that learners with disabilities have limited access to quality education, and also they have long-standing impacts on ability for the human development. So with this is where the county has been guided to develop the 3 key pillars for children with disability to be addressed. Next slide, please. So one of the things that the county has done is to start off with registration of children with disability in the entire county. And that data has been very useful. Next slide, please. A number of things that have indicators that have come out from this registration is having data that is disaggregated within the locations and also girls and boys, and that is quite helpful in terms of planning. Next slide. Also, other parameters we have been able to see in terms of domains of disability, what the children with disability in that particular county require, and how then the county can prioritize in terms of providing accessibility and also access to other social sectors. The highest disability in the county is physical, followed by intellectual, and the least was deafness. Next slide, please. With this data also, we've been able to see children with disability, how they are able to, who are attending school and who are not attending school, and what the barriers are. The age group on which kind of, which particular cohort that is mostly affected, so the programming is around that. We've been able to also to see in terms of registration with the National Council of Persons with Disability, how many have the disability card and how many have the birth certificate as well. Also in other parameters, we've been able to see the kind of assistive devices that the county would require to provide to these children with disabilities. Additionally, in terms of planning and programming, to see the household head and the composition. And as we know, social protection programs thrive with prioritizing women. Next slide, please. So far, the program has been able to have cash transfers to households with children with vulnerabilities. We have been able to have a number of children who have been assessed with the early assessment resource centers and been placed in schools. And also we've been able to support children to have medical assessment that will enable them access disability cards. Next slide. So with this, we've learned quite a lot in terms of community sensitization and mobilization, how it is important to mobilize communities to create awareness on disability. We've learned it's important for us to continue registering children with disabilities, even after we've done the mop-up, so it will continue and have them referred to the social sectors for services. Also, it's been key that the early identification for children with disabilities will support the county for planning and budgeting to ensure there are available resources for that. Finally, the key things that the county is planning is to increase private sector engagement, where it's a key potential for the county to partner, to keep on supporting the children with disability registration to be enrolled into the program and be referred to other social sectors, especially to the health and also the National Council to access the disability card. Also, there is need to engage on education policies that will take into account inclusion so that children are not segregated. And finally, prioritize the social protection in the county in budgeting and planning the framework. Thank you.
Thank you very much for this presentation, Suzanne. I think it's extremely interesting to see how a program can be supporting the start of an integrated support for children with disabilities, including this interaction between social protection and education. I would like now to introduce our next speaker, who is Flavia Mpanga from Uganda. And Flavia will talk to us about something that is extremely important for children, which is early identification and intervention. Suzanne mentioned how important it was. And this is a key challenge because we know that it's more challenging to identify persons with disabilities, children with disabilities in early age. So Flavia, the floor is yours.
Good morning, good afternoon, good evening, everybody. Thank you for joining the webinar. My name is Flavia Mpanga. Does everybody hear me?
Yes.
Yes, I can hear you, Flavia.
Okay, and I'm sharing my screen. So I'm going to share the experiences from the interventions of disability in early childhood. It's a pilot project that's being implemented in 5 districts in Uganda. It's funded by, this pilot project has been funded by the H&M Foundation, the Swedish H&M Foundation and the Norwegian government. And it really aims at identification, early identification, assessment, and linkage of children with disability and developmental delays to various forms of interventions using a protocol which has a referral pathway that I'll explain in a minute. And this pilot is being conducted in 3 countries, Uganda being one of them. I'm presenting from Uganda, Peru, Bulgaria, since 2018. In Uganda, it was implemented in 2 districts and 3 districts were added in the early expansion phase. How did we start up this project? We wanted to ensure that sustainability was thought about right from the get-go. So a national early identification of disability in early childhood, IDEC committee was set up, and it comprised of Ministry of Health as the chairperson. It had Ministry of Education, Gender, National Council for Disability, academia, and also persons living with disability. And this same committee has been replicated at the district level, at the various district level in the 5 districts where the project is being implemented. So far, we have trained 16 master trainers on a tool that was developed by Professor Gladstone from the Liverpool School of Tropical Medicine, and it's called the Malawi Development Assessment Tool, the MDAT tool. We've trained 16 national master trainers on that MDAT tool. It's an assessment tool, and 12 national trainers have completed the caregiver skills training tool, as well as a tool that was jointly developed by the Cerebral Palsy Foundation in the USA, called the Early Motor Development Support Tool. So these tools are very, very important in the monitoring of the children that we've assessed and discovered have some disability and are managed at community level. So the training cascade went down, and the district trainers have trained 26 health workers, 14 teachers, and 50 VHTs. These are community health workers on the Malawi Development Assessment Tool, the Caregiver Skills Training Tool, and the Early Motor Development Support Tool so far. Now, this is really the hallmark of our project. It's a 3-tiered project, 3-tiered protocol, where in the tier 1, we have at community level, the community health workers and caregivers assess children on the MDAT, using the MDAT tool. The assessment is conducted at community level, as well as at schools and early childhood development centers. If the children have passed and no disability in any of the 6 domains is detected, these are directed into the mainstream ECD services. And early childhood development services are in 5 streams, and I'll elaborate on that later. If they fail, they go to the health facility, and the health worker will use the validated original MDAT tool to conduct a full assessment. And they'll also use the visual and hearing screening that's done at that level. If any of those children are found to be with a disability, they are put into tier 1 for those that are mild and moderate. And that is where the health workers, the teachers, the village health team members, the community health workers, train the caregivers and mothers and fathers on the caregiver skills training, so that most of the actions are done at community level and in households to try and support these children overcome some of this disability. And the motor support is given at this level at tier 2. And in case the disability is really advanced, then the tier 3 is called in, and that is where you have specialized interventions, especially for the ASD spectrum, the cerebral palsy, which is the motor and epilepsy in cases, epilepsy and mental health or any other disability in that domain. But most importantly, the hearing and visual screening is conducted very early when the children are 0 to 3 months, and it starts at 6 weeks at the health facilities, and it's conducted both at health facilities and the community level for hearing and for visual and hearing screening. And corrective action is taken early. If you remember how the child develops, we need to detect the visual and hearing impairments as early as possible so that corrective action is done. For the community level at tier 1 and health facility screening, it's done at 9 months and linked to immunization clinics typically. And at community level, each community health worker is linked to a household. They may have about 25 households by community health worker, and they will be able to assess children at 9 months for these disabilities using the MDAT. They also look at any of those children that are less than 3 months, starting at 6 weeks, for visual and hearing screening. So what are the ECD services, the early childhood development services that we refer these children to? These are along the 5 streams of obviously health, and in health particularly to ensure that the children undergo the immunization according to schedule. There is nutrition for the growth monitoring and treatment of severe acute malnutrition or moderate acute malnutrition, because we know that once children are malnourished, and their growth may be impaired, and they may be prone to disability. And also malnourished children manifest they can come up with all sorts of disabilities. So we need to really look out for nutrition using the NEWAC screening. Then we refer them to early learning centers and stimulation, responsive caregiving, where it includes play and stimulation. There is a whole array of interventions in there, and also safety and security so that the children are protected. There's been a mapping of all these services in the districts where we are doing the pilot, so that parents know exactly where to go when the health workers refer them. The other early interventions for disability in early childhood interventions include, as I told you, the caregiver skills training that has 9 modules, taking through over a 9-week period the caregivers, mothers and fathers, on how to, train their children to do all sorts of actions that will help them, improve the disability as they said, and also the motor development support, which has 9 modules conducted again over 9 weeks. If there is referral to tertiary specialized care, it is along those 5 streams as well. Next is, so far we have identified 754 children with disability using the MDAT tool in the 2 districts of Mubende and Kassanda, where we really are narrowing down to try our model as a proof of concept for a model that can be scaled up across the country. And we're careful to do it very well with the health workers and the village health teams, who are the community health workers. 85 children with severe disability were referred for specialized management with UNICEF support, all sorts of specialized management, from water to hearing and hearing and sight support. And the VHTs, who are the community health workers in Uganda, are currently conducting orientation of caregivers in the caregiver skills training modules, and this has been translated to the local language, and it's extremely helpful because the bulk of the children have moderate disability, and it has to be managed at community level. These are some of the pictures that show you the plenary session of the training that was done even during COVID, and obviously social distancing was observed, wearing of masks, and all those SOPs during COVID. These are health workers and teachers examining children for disability during a practicum, which was part of their training. And this is a VHT who was conducting an assessment of a mother for a child who had probably, that was CP. And that is all we've done so far. We expect that at the end of this project, in about 2 years, we'll have a model that will be scalable across the country and also comparable with Peru and Bulgaria. Thank you.
Thank you very much, Flavia, for this very interesting presentation in a context that is fairly difficult in terms of access to services and development of services. And I think it's really important to show that steps can be taken in any given context to improve early identification of children with disabilities. It's also a presentation that connects very much with our next session on disability assessment, because quite often there is not enough connection between early identification and the work on disability assessment for social protection. Thank you very much. I would like now to ask Nora Sharbani, who is education specialist for the Europe and Central Asia office of UNICEF, to tell us a little bit more about some of the key challenges in the region with regards to transforming social protection and care for the inclusion of children with disabilities. Nora, the floor is yours.
Thank you, everyone. I hope you can see my presentation. Sorry. Is it okay? Can you see it?
Yes, not in full screen though, if you can.
I think it's okay now.
Yep.
Okay, very briefly, as Alex announced, I come from the Regional Office for Europe and Central Asia. I'm the disability focal point. And this presentation is really to give you an overview of where we stand in terms of disability inclusion and how we see the increasing role of social protection, the transformative role of social protection in advancing this agenda. So I will not focus on specific country examples, but just talk about some trends, some numbers when it comes to our region. So this is a region that has 10.8 million children with functional difficulties, according to the latest UNICEF Global Report. We remain a region with the highest rate of children in general in residential care. This rate is 666 per 100,000 children compared to the global rate of 120 per 100,000 children. Children with disabilities are 17 times more likely to be institutionalized, and they're excluded from service provision. More specifically, 1/3 of out-of-school children are children with disabilities. As I mentioned, this has been a region with a very dynamic disability inclusion agenda, which has been implemented in the last 2-3 decades. And these are the main streams of reforms. Obviously, given the strong legacy of institutionalization in the region, many countries and governments have prioritized the institutionalization. The focus has been on closing institutions and introducing alternative care options and community-based services. The other stream has been inclusive education. The focus has been on increasing capacities of teachers and schools to enroll children with disabilities in learning, but also organizing this additional support by deploying teaching assistants, reforming special schools into resource centers, all for the purpose of providing this additional support that children with disabilities need to participate in learning. Early intervention has been one of the key pillars. It did not exist in the past. Many countries have introduced models, as explained by our colleagues in Uganda, which have focused on bringing new approaches, capacity building, institutional setup, changing legislation and funding. And in some countries, these models have been successfully scaled up. Disability assessment dominates the current agenda because very often in these countries, the system of categorization was the one that was sending children in institutions. So to prevent institutionalization, with this motivation, many governments embarked on reforming disability assessment and facilitating shift towards the human rights model to a disability assessment. So where we are, although data is not new, this is based on Transmoney database that collects data from all governments in the region. We can see that the impact of institutionalization has been positive when it comes to children in general, but when it comes to children with disabilities, the rate of children with disabilities as part of the proportion of children with disabilities as part of the overall number of children in institution is actually increasing. This obviously masks the disparities that exist in some countries where this rate is as high as 70 to 80%. But it may be because also there is more awareness on disability, and children with disabilities are more identified, but also the institutionalization agenda is now also including children with disabilities in special boarding schools, which are many in this region. So I will just give you a brief and very broad overview of what has been some of the lessons learned. When it comes to cash transfers, obviously this is a region where cash transfers for children with disabilities and their families exist across the countries. But there are issues with adequacy of these transfers when it comes to the actual cost faced by cost of disabilities faced by families. Community-based services, which are the most important to prevent institutionalization, but also to ensure full participation of children with disabilities in communities, have been introduced as part of the sectoral reforms that I mentioned earlier. And there have been emphasis on some services more than others. For example, we have seen proliferation of daycare centers across the country, across all countries, or early interventions, or personal assistance, but less emphasis was put on some, for example, critical therapies, interventions, respite care, you know, even basic things like sign language interpretation, accessibility, etc. We see that if we look at the continuum of services that need to be in place to support children across the life course and to enable their full participation in community life, we see that many services are lacking. They are fragmented and they overlap. Overlap in the sense that, for example, daycare centers are being established both as part of inclusive education reform and childcare reforms, and very often the mandate or the role is not clearly defined. And also, these services mainly exist in urban areas, leaving children who live in remote areas or disadvantaged areas without any support. And obviously, most importantly, there is less consideration on quality outcomes of children. So the impact of this support on the lives of children, and especially during the transition period. There will be a separate session on disability assessment, but I just want to highlight the challenges that we are witnessing, that this region has, in countries have different levels of assessment, which usually are not aligned. For example, the one that exists in health or social protection or education, the medical approach persists, and there are not very strong links to gatekeeping mechanism, case management, and service delivery. And I want to emphasize the lessons learned from COVID-19 pandemic, which I'm sure they are very well known to all of you, but for us, it really emphasized the importance of participation of persons with disabilities, and also relying on the service models or capacities of civil society and OPDs in service provision. There was a UNICEF survey which showed for this region that during the pandemic, 70% of the support to children with disabilities was provided by this organization. So this is the way forward for us in terms of key pillars of reforms. how we as a regional office see this agenda in terms of support we are providing to countries, but also where governments are heading in terms of the next steps. Obviously, we want to continue with the disability assessment reforms. We are currently undertaking a mapping of assessment reforms across countries, which will take stock of of these lessons that are mentioned, but more importantly, it will provide some guidance on the way forward, because in terms of the approaches used, but also in terms of how the systems are set up. In terms of services, community-based services, many countries are conducting mapping to identify gap and opportunities, but we think that one of the most important aspect is really to do costing of services and to identify funding to create this fiscal space for incorporating the funding for services in the national reforms. Alex mentioned today, but you also heard from Georgia yesterday that there are efforts across countries to estimate the additional cost of disability, so that that transfers that families are receiving correspond to the actual cost of disability. A very important pillar of the reform is this better articulation of or combination of package of transfers and services. In the context of COVID-19, many countries are opening the doors for private sector and OPDs to provide services. And finally, I want to underline once again the mechanisms for participation of children with disabilities in service planning and design. You heard yesterday from Georgia that everything they're doing is in coordination with the Disability Advisory Council. Such bodies and mechanisms are established across countries in the region. So this is where I stop. Thank you, Alex. Thank you all. Over to you.
Thank you very much, Nora, for this comprehensive and yet succinct presentation. So we heard from Kenya and we heard from Uganda, where governments and local authorities are trying to build systems. Nora presented us about some issues of countries in Europe and Central Asia that are trying to transform existing systems. I would like to go now and ask Ala Darwish, who is Social Protection Officer in Syria for UNICEF, to tell us more about how integrated support, combining cash transfer, but also access to services, how does that work in a humanitarian context? Ala, the floor is yours.
Yes, thank you, Alex. Hello, everyone. Just continuing where Alex has stopped, our program is the Integrated Social Protection Program for Children with Disabilities, which is implemented in a very difficult humanitarian situation. As you know, today, I mean, this month marks the rim of the 11th year of conflict in Syria. So I will just explain to you about the steps. Please, next slide. So this is the program. It is a model of integrated social program. It combines cash transfer and case management services. Mainly, it is a cash plus program. This program is not, invented by UNICEF. It is we built this program based on the National Social Protection Scheme for people with disabilities. So we used an already existing system, which was interrupted due to the conflict in Syria, and the cash assistance is a regular and unconditional cash, which is a monthly amount of $40. It is also accompanied by a case management component, which is accompanying the child and supporting them, children with disabilities, to facilitate their referral to social and social services, and to increase their social inclusion. The program duration is currently 24 months. This is one of our main achievement last year, which was extending the benefit from 12 months previously, since the start of the implementation, to 24 months currently, just to ensure better sustainability of the provided cash assistance and services. Our beneficiaries are, of course, children with severe disabilities. We have 12 forms of disabilities, including cerebral palsy, profound and intellectual disabilities, also visual and hearing impairment. Since the start of the program, which was started during, started 2016, we have reached more than 30,000 children with disabilities across 7 governorates in Syria, which are also accessible to us. We are always trying to expand to new areas where we didn't intervene yet. Of course, the security situation is still preventing us. Next slide, please. I'm just highlighting key achievement of our program intervention during 2021. We reached over than 11,000 children with disabilities. 500 are girls. We have this gender issues in our program. Only 40% are reached with our program, and this is one of the challenges we faced during our implementation. Of course, this is related to the cultural issues, to the type of disability somehow, and we are trying to address this through our continuous advocacy to ensure more inclusion of girls with disabilities in our program. We have a network of more than 300 case managers who are supporting our children and facilitating their referral to the social services, including access to obtain disability card, which helps also building the database of the government, which was interrupted as well during the crisis. So we are trying to refer children who doesn't have the disability card to obtain a new one, which helps more of building the database of the government. One of our support to the government is to work at the upstream level with the government to develop and roll out the National Social Protection Integrated Management Information System, which is done at 3 phases. This system is helps just a minute, sorry. So the integrated social management information system brings together all the information systems and various social protection programs and schemes into one integrated MIS that will also function as single registry. We have the efforts has started 3 years ago, and we have 3 phases. Now we are at phase 3, and we are hoping to finalize the database registries for people with disabilities and for orphan children, so they can be integrated in the MIS. Next slide, please. During the program implementation, we always have a post-distribution monitoring survey. We ensure that we conduct this through the lifetime of the implementation. The main objectives of implementing those surveys is to understand the socio-economic characteristics of families benefiting from the program, assess the effectiveness and efficiency and impact of the program, of course, during the program life cycle of the implementation, and to collect feedback from beneficiaries and level of satisfaction with the program. I'm sharing with you most recent key highlights of our PDM conducted in one of the governorates in the northeast of Syria, where we have a very complex security situation combined with a very economic situation, I mean, due to the sanctions, to all the current economic situation where Syria is suffering. I'm sharing with you the key highlights related to the education situation of the children, where we have 70% of the children with disabilities have never attended schools. Of course, this is related to health issues mainly because the type of disabilities is preventing children with disabilities from attending schools, and also the lack of specialized education in those areas where we are targeting, especially rural and remote areas, is not making this easy for children with disabilities. We are working with our partners and the government to ensure this is our top priority to address this obstacle. We have also 75% of children with disabilities were referred to essential services by case managers, which highlights the essential role of case managers, the case management component that case managers are playing in our program. And we have also strong positive impact of the program on increasing the availability of disability cards. As already mentioned, this is the main proof of disability. We ask our children to be enrolled in the program, and it is really essential they are obtaining this. Also, it helps them to acquire more support from the government due to obtaining this disability card. Just please, next slide, just some graphs. This is the education status, where we have 70% of education out of school compared to only 19% attending schools. Next, please. Yes, this is the percentage of children who received referral services. As mentioned, we have 76% of children receiving services through the case managers. Next, please. Okay, I'm just sharing with you the type of services where we have 53% of services provided by case managers is related to the legal documentation or the disability card. We have 51% related to health services. Least service provided is protection, and we have only 5% of education services provided. Next, please.
Ala, I will ask you to wrap up, please. Thank you.
Yes, and this is my last slide. So we can see that it improved access to disability card due to the support of case management. The key message I want to share with you is that from our experience in implementing this program for now more than 6 years, it's not easy to implement such a sensitive program in such a complex humanitarian context, but it is never possible. Thank you, and
thank you very much, Ala. I think it's once again what you showed us together with other speakers is whatever the context, there is something to be done to provide integrated support for children with disabilities, and trying to increase this coordination and this combination between social protection, health, and education. Of course, social protection cannot solve every problem. And as you mentioned, if education services are not available or are not inclusive, it makes it very difficult to actually increase this access. Thank you very much for those presentation. I would like to briefly give the floor to Mr. Moustafa, who is a representative of the county of Mombassa, to tell us a little bit about the commitment of the county of Mombassa to support children with disabilities. We heard about the Stride program, and we know that in many countries, local government have a very key role to play in delivering support services for adults and children with disabilities. So, Mr. Moustafa, if you are with us, can you take 2 minutes, 2-3 minutes to share your reflection? Mr. Moustafa? No? Okay, so if not, I have one or two questions. I would like to go to Flavia. Are you still with us, Flavia?
Yes, I am.
Yes, Flavia. We had some question with regards to the connection between the early identification and intervention and community-based rehabilitation program, if any, in Uganda, as well as a question about the financing of the project and to which extent the public finance of Uganda are taking a share or are planned to take a share in this program. Flavia?
Okay, thank you very much for those two questions, important questions. The community-based rehabilitation services are being carried out based on an innovation that has been built into this program, and for monitoring of the developmental delay as well as motor support, we're using the caregiver skills training that has 9 modules that help caregivers go through the various actions that would help their children develop better, and also the motor development support training so that they can help families and caregivers do the right things so that there is proper fine gross motor development for their children. So that is what we have as an innovation in Uganda for the rehabilitation at community level. In terms of financing from the government coffers, we are piloting, as I told you. We are using resources from H&M Foundation and from the Norway government at the moment. We are going to undertake a costing of the whole intervention and see what type of costs lend themselves to scale up, and present to government a scalable model that will be eventually financed by the government. But already there is a lot of appetite from members of parliament. They want to have this project carried out in most of their districts. We are telling them to hold on until we've perfected our model, and that will probably come within the next 2 years. Thank you.
Thank you very much, Flavia, answering some of the question of our participants. Unfortunately, there are few more questions which we will seek to answer after this session. We have to close to go to the next session. I invite all of you to join the next session on disability assessment, which we mentioned a lot in this session on children with disabilities. The mechanism by which government figure out who are persons with disabilities in need of support and who will receive support. And we know those are very sensitive issues. I really would like to thank all the speakers that gave us this diversity of context and issues and project and innovation, and that showed us that no matter the context, no matter the situation, there are steps that we can take to build a more inclusive social protection and care system for children with disabilities. Thanks to all of you, thanks to the interpreters, and see you in the next session. Thank you very much.